Good afternoon, everybody. Thank you very much indeed for coming. In fact, it's evening. Soon it will be drinks time. But before then, we'd all love you to join us. We're going to be entertained and educated. And it is really a wonderful pleasure. I have to say that Pete has a long history. Our paths overlapped. He used to be a Mary's man. There was no room for a Mary's woman, but I was one of those at one stage. And I have to say it's great to be here together at George's. This man is terrific, both from the research point of view, but also from clinical service delivery. He's very highly valued by his colleagues, I'll tell you that for nothing. When you arrive in an organisation, you begin to pick up words, sentences about people, and I hate to tell you, but people are very ready to categorise their colleagues, and you came out with a gold star, so well done. We're going to hear much of Pete's work. I did take the opportunity to go around some of the research facilities, and in fact I have tried, but frankly failed, on about 3 occasions to record a vlog with Pete, because he's always dashing off, or indeed going to theatre or to save a life, but I do think that that's much more important than recording a video with me. So thank you again for coming. It's lovely to see family and friends as well as many illustrious colleagues here. So we'll be delighted to hear what you've got to say, and then I'll hand over to Ian for the vote of thanks at the end, just to say there is going to be a reception afterwards up on the second floor. Thank you very much.
Thank you very much, Jenny. Well, first of all, I just want to say thank you all very much for coming, and I know some of you come a very, very long way, including some people who've flown halfway across the world, so I'm very touched you're able to make it. And, well, without further ado, let's move on to reconfiguring care. If you're under 10, that's the highlight. Okay, so I'm going to talk about a few things. Most of the audience is non-medical, funnily enough, so I'm going to talk a bit about what vascular surgeons do and what challenges we've faced as a specialty, and some of the solutions proposed and some of the mistakes made. And I hope at the end of it you'll know more about vascular surgery and know quite a lot more about me as well. So this is quite close to my heart. This is a case I'm going to use to explain one of our major pathologies we look after. So it's a 69-year-old white male scientist who has upper abdominal pain for 2 to 3 days. He's a pipe smoker and overweight. This clearly is not an overweight person, but if you were to ever lie down and see a lump like that in your tummy, please phone my secretary. That's quite a bad thing. And he had a pulsating mass in the abdomen. This was Albert Einstein, and he was born in Germany in 1879, and in the mid-1940s was admitted with abdominal pain, and his surgeon described a grapefruit-sized aortic aneurysm in his abdomen. And the treatment at that time was wrapped in cling film. So his belly was opened, wrapped in cling film, and stitched back up again and sent on his way. And surprisingly enough, it lasted okay. And it wasn't until 1955, some 7 years later, that he finally died of an aortic rupture, declining further surgery. And aortic aneurysms are a big part of what vascular surgeons treat. And the ways we can treat it, this is an aneurysm on the right-hand side, below the level of the kidneys. And you can either stitch in a graft that's made of plastic or fabric. And in the early days, you have a seamstress sitting in the operating theatre cutting up old nylon shirts and stitching them to your requirements, and you pop it in and don't worry about the infection. But nowadays we put in endovascular stent grafts, as you can see on the left-hand side, and we use 3D imaging, and these are keyhole procedures, can be done under local anaesthetic. And clearly things have moved on considerably since the early days of wrapping things in cling film. Vascular surgeons also treat patients with stroke, and you may well be aware of the Act Fast campaign, which is a global campaign to reduce the risk of stroke and to identify patients with stroke earlier and get them to have treatment more quickly. In a proportion of patients with stroke, the carotid artery, that's the arteries that go through the neck up to the head, sorry, Anna, go up to the head, have these narrowings and these kind of mucky ulcerated plaques. And it's a vascular surgeon's job to kind of clean that out and make it look smooth and prevent future risk of stroke. Not to be outdone of the brain attack and the heart attack, the lowly foot now has a foot attack. And we deal with patients with critical limb ischemia, as in the patient in the middle who's already missing a toe. That's where there's not enough blood going to the foot. And diabetic foot sepsis, and that's the photo on the left-hand side, the right-hand side. And you can, diabetes is getting more and more common, and this is going to be a big problem for us all going forward. And the techniques we have to treat these are either surgical bypasses, which leave big scars in the legs but can be very effective, or we can use a range of wires, catheters and balloons to perform an angioplasty, again under local anaesthetic and keyhole procedure. Sometimes things don't work out so well and we end up having to do an amputation. And the techniques, I'm afraid to say, have not really changed since this picture of the Middle Ages. Certainly the surgery is the same. However, the global procedure around it in terms of rehabilitation, getting patients up and walking around and walking on prostheses is very different. And this is now a very big multidisciplinary team to get patients back to independent living. And finally, Anna, you might want to close your eyes again. We are an integral part of the trauma service, and this guy won a Darwin Award, I think, on my fellowship in Australia because he decided to clean his combine harvester with his leg. We did manage to save his leg and he got out a couple of weeks later. So these are the kinds of things that vascular surgeons do. But there's a real problem because we're actually not very good at it in the UK. This is called the Vas Canet Report in 2008, and it collected data from all of Australasia and Europe and presented the results for aortic aneurysms and carotid surgery. And we were the worst in terms of clinical outcomes, in terms of mortality, with nearly an 8% mortality for aortic aneurysm repair, and the highest rates of stroke and death after carotid surgery. Not only were we worse than other countries, but huge disparities were seen between individual hospitals within the UK, with high mortalities in some hospitals and lower mortalities in others. And at the time that the NHS Atlas was beginning to be produced, huge differences in amputation rates around the country were also shown. And you'd intrinsically think that the northwest and northeast might have the highest amputation rates given the population, but actually it's the southwest was by far the worst. There's huge inequalities across the country between hospitals, and the UK lagging behind European and other international countries. There's an argument as well that we're also far too conservative in the way that we treat patients. This is a very famous study, Janet authored it, called the UK Small Aneurysm Trial. And this helped to define when we should treat aortic aneurysms. And in men, the international guidelines is we treat them at 55 millimetres, and in females around 50-52 millimetres. And in the UK, this trial has been interpreted to say that we cannot treat patients at diameters below that. Elsewhere in the world, that simply isn't the case. And if you compare this to the USA, they're treating 40% of patients below that threshold, and 17% of females below that threshold. And what that does, or rather what not treating patients smaller than that does, is force the threshold at which you treat aneurysms up higher. So in the UK we don't treat aneurysms as a mean across the country till they're 64 millimetres, and in females till they're 62 millimetres. An aortic aneurysm rupture is absolutely dependent on aortic diameter. So as the aneurysm gets bigger, there's an exponential rise in aortic rupture rates. And so a 10 millimetre increase is a very significant increase in terms of whether a patient's going to rupture or not. And this is seen through the rate of intact repairs. So this is of elective aneurysm repairs. In the USA, we've got a rate of 62 aneurysm repairs per 100,000 population. And in the UK, we're half that, 30 per 100,000 population. Now, that's a difference of clearly double. The rate of aneurysm-related death in the UK is in the region of around 45 per 100,000. It's coming down over time, but as an average 45, and this is over the last 10 years. And in the USA, the rate is around 12, 13 per 100,000. So in the States, they're operating on smaller aneurysms, they're doing twice as many repairs, but we have 3.5 times as many aneurysm-related deaths. It certainly makes you think about how we've interpreted that trial within the UK. You're bored. This is Lord Voldemort, Ted. I think you know that. Or as we call him, the Dark Lord. And there's someone else called the Dark Lord. Professor Sir Aradazi did his next stage review at around the same time as we were being told that we were not very good at vascular surgery and had poor mortality rates and were not treating the right people. And this was one of the most excellent pieces of work you can look at. It gave us the first workable definition of quality in healthcare. It broke it down into clinical outcomes, cost effectiveness, patient safety and patient experience. And these were all adopted into the NHS outcome framework. And it was clear, led by Sir Bruce Keogh, that the currency of transactions within the NHS was now going to be clinical outcomes. And for vascular surgery, this is a really good thing because we have some clear structures we can analyse, some clear processes, and our outcomes are about as hard as you can get. If you get vascular surgery wrong, patients die, they lose their legs, or they have strokes. And we can look at some of the softer process measures, maybe the percentage of patients getting minimally invasive techniques or having their own vein used for bypass rather than plastic, which we know to be better. We have hard outcomes, and there were some structures that clearly needed further investigation. What happens if surgeons specialise, and what happens if you change or look at different hospital volumes and surgeon volumes, so the number of cases performed per year. I'm going to focus on these top two with respect to clinical outcomes for the remainder of the talk. With respect to specialisation, vascular surgery grew up out of general surgery, and a traditional list would have been a bowel resection, followed by an aneurysm repair, followed by a nice gentle thyroid to round the list off. But we know for bowel surgery, your rate of getting a stoma and your rate of cancer clearance is less if it's performed by a specialist bowel surgeon. We know for thyroid surgery, your rate of nerve injury or your rate of accessory glands called the parathyroid glands being inadvertently removed is less if they're performed by specialist thyroid endocrine surgeons or cath ENT surgeons. So what then for vascular surgery and aortic aneurysms? This was a large study performed in the States, and we've got general surgeons on the right, cardiac surgeons who in the States do vascular surgery, and vascular surgeons on the left, and the in-hospital death rate up and down. And there's a factor of about 3 difference between vascular surgeons doing aneurysm repairs and general surgeons. And cardiac surgeons not far behind the general surgeons. For carotid endarterectomy, what's the 30-day stroke and death rate? Again, if a general surgeon does it, nearly an 8% stroke and death rate, as opposed to around 3% for a vascular surgeon. And these outcomes are not just limited to the perioperative period. If you follow these out to 8 years, the gap actually just gets wider and wider. So things that happen in and around the time of surgery have an impact for many years afterwards. As a result, it was clear we needed to become a separate specialty. And a lot of work was done to move vascular surgery away from general surgery. And it's quite a difficult process. You actually have to go through a very legal process and enter the parliamentary statute books. So this didn't happen till around 2012, by the time we were finally designated a separate specialty. I think it's absolutely necessary, but I think on balance we did it too quickly, and there was too much emphasis on how we could become a separate specialty, and the impact on other specialties and the way we interact around the hospital and the knock-on effect of junior and senior on-call rotas. To my mind, this was done too quickly and it was too disruptive. I think we would have always ended up at this point. But I think another year or two playing this out and seeing what the impact would have been more sensible in retrospect. Another bit of an aside, and there is a link here, I promise. I used to spend quite a lot of time on the river, and quite a few people here are rowers. And Bill was my coach for many years, and Alison, hello. This was occasionally when I had a good year and avoided injury and sickness, and there's a fair wind blowing, I got selected for the national team, and this was at the under-23 age group World Championships. I draw your attention to two things. One is the empty lane here. There is a boat up here, which is a long way ahead. It was a Russian boat, and if I knew then what I know now about state-sponsored doping, I'd have had a word or two at the finish. But anyway, the other thing is this, and this is really a comment about investment. So the majority of my time at medical school, and by me, the vast majority, was spent at this place, at the Imperial College Boat Club. And when I first started, it was a small boathouse. The gym was in the male changing rooms, and there wasn't enough space for anything, and nonetheless we managed to achieve some excellent results. We applied for a grant from the Lottery Council, and were given a sports fund of around 700,000. We managed to double the size of the boathouse, and this was about investment in facilities. There clearly was a seed of something very good, and a decision was made to invest in that, improve the facilities around it. So this wasn't just a big gym and a big boathouse, there were physiotherapy suites and all sorts of other things. And from that, we managed to go even further. So within 2 years, this crew went on to the Sydney Olympics, many of them through the Imperial system. And in fact, for the 18 months before the Olympics, they trained at the Imperial Boathouse, that new building you've just seen. And they came home with a gold medal. So if you find areas of excellence and invest appropriately, good things can happen. And I think the same is true of healthcare. And that's really the next question. What happens if you find seeds of excellence? Can you define them? And can you change the way services are configured in order to access those better centres? Don't worry about the statistics behind this. It's called a meta-analysis, and essentially what you need to know is there's a line up and down the middle that means there's no difference. All the values to one side designate one thing, in this case high volume, and all the values to the other side designate low volume. And essentially what this tells us is that all the studies worldwide said that if you have aortic aneurysm surgery in a high volume centre that was sentencing more than 40 cases a year, you had a 40% lower mortality than if you went to a centre with a low volume. The problem was that all those studies were from the US and various other countries, but none from the UK. So we decided to repeat that study and took the UK data. This is called the Hospital Episode Statistics, which is a national data set for the UK, and looked at the outcomes of elective aortic aneurysm repair. And we found that there's a mortality rate of 7.5%, which is very consistent with our Vas Canet data, despite being a completely different data set. But more importantly, we found that low volume hospitals tended to have higher mortalities. And these are patients with elective procedures having a 30% mortality, a 1 in 3 chance of dying. And higher volume hospitals tended to have mortality rates that were not only lower, but well below the national mean. A slight aside was that there were a number of hospitals that had very much outlying mortality rates, and these had underwent further investigation. Of course, when you want to shoot down any kind of study that you don't like the message for, the easy thing to do is say the data are no good. So we wrote to all the surgeons around the country and asked them to provide them with their data for the number of cases they'd done and the deaths from their cases over a prolonged period. And what we found is this, when the data came back through, that was a Freedom of Information Act request. In the blue lines we've got the hospital data, and in the orange line surgeon data. Low volume hospitals and surgeons on the right hand side, and high volume hospitals and surgeons on the left hand side. And there's a clear reduction in mortality in high volume hospitals with high volume surgeons. Perhaps more shocking was this issue of turn down. I just want you to focus on the blue segments here. So these are the patients who are considered for treatment but were not given treatment due to social circumstances or being too unwell and so on. In high volume hospitals the turn down rate was only 10%. In low volume hospitals it was 35%. You'd think this would go away, but these are the data that have just come out from the National Aneurysm Screening Programme. This is all males nationally, aged 65, who have a one-off ultrasound to determine whether they have an aneurysm or not. If that aneurysm exceeds 5.5 centimetres, they're offered surgery. And we have a load of hospitals down here, or screening units, with turn-down rates of 5-10%. And we have a load up here with turn-down rates of 15, 20, 25%. So you go to this hospital, you've got a 1 in 4 chance of never being offered surgery. Then you go here, and you've got 3% chance of not being offered surgery. It's really shocking, and it hasn't changed. These are current data.
I'm a little nervous with all these waivers we have to sign.
Mike, this is a national park. People are completely safe here.
So, I don't know how safe we are actually. Because if you don't treat an aneurysm, it ruptures. Or it may rupture. One of the problems is we can't predict who's going to rupture and who isn't. Our best predictor is aneurysm diameter. This is a very large aneurysm. This is a very large hematoma. And aneurysm rupture carries a 75% mortality. Half of patients never make it to hospital, and of those that do, half never get through surgery. So we extend our hypothesis that centralisation may help aneurysm outcomes to look at those who've had ruptured aneurysms. In the light blue lines we've got the emergency workload of hospitals, small hospitals on the right, high volume hospitals on the left. And in the dark blue, the overall workload, so elective and emergency bundled together. And this is really shocking. If you go to a low volume hospital, you have over a 50% chance, nearly 60% chance of not being offered surgery for a ruptured aneurysm. If you come to a high volume hospital, you have a 20-25% chance of not being offered surgery. So there's a 3 times difference whether you're going to get surgery for a life-threatening condition or not. When you add into this the fact that if you go to a low volume hospital, you have a 60% mortality and a high volume hospital a 40% mortality. There's a 3-fold difference in whether you get surgery, and then a 20% difference whether you survive that surgery. I think there's a real problem and we still need to address this. So what then if you bring hospital volume together and surgeon specialisation? Well, here we have low volume hospitals on the right, high volume hospitals on the left. General surgeons in blue, cardiac surgeons in orange, and vascular surgeons in grey. And if you combine high volume surgery with specialist high volume surgeons, you get the lowest mortalities of only around 2%. And there's a very famous study in the States where they took low volume surgeons from low volume hospitals and put them into high volume hospitals, and they adopted the mortality rate of the high volume hospital. So there's clearly institutional learning, there are institutional factors that drive the mortality rate and the outcomes of surgery. And if this isolated pools of success, might you be very good at aneurysms and rubbish at bypasses, for example? This work was done by Sid Sina, and if you take the entirety of vascular surgery and then pull out individual procedures, what you find is if you've got a low mortality for the other 6 procedures we do, then you also have a low mortality for the one under investigation. And the differences are quite stark. So for aneurysm repair, if you're good at vascular surgery in general, you have a 3% mortality. Whereas if you're less good at vascular surgery in general, you've got an 8% mortality. And this is carried out to a year. So these same patients have an 8% mortality at a year from the better hospitals, and a 14% mortality from the smaller hospitals that are not achieving such good results. There's something systemic here, and it's carried out well beyond patients leave hospital. I think this supports the notion that centralising care or networking care is a very positive thing. This has to be done in the correct fashion. So it's about bringing major surgery into larger units such they can be delivered within that institutional learning environment. But there's a network with local hospitals, and there has to be interplay between them. And the central unit also has to take charge of or ensure that pathways are correct between the local unit and the central unit. Otherwise, patients won't get the access to care that they need. The further slight aside is we spent a lovely year out in Australia, in Adelaide. Lived just here, there or thereabouts, on the North Adelaide, just by the Adelaide Oval. And we had a really different year. I was on call that night. it's slightly different to tooting, unfortunately. Anyway, we worked in a hub and spoke system in Australia as well. And the hospital was in the middle of Adelaide, and this was our immediate network. Coming up to here, Port Pirie, Port Augusta, Whyalla, 6-hour drive, you have to go over the top. Port Lincoln, an hour flight, and then down to Mount Gambier, Murray Bridge, again at a decent distance, several hours in the car. In fact, it was bigger than that, because once a month we did a week's clinics and operating up at Alice Springs. And we took ruptured aneurysms from Darwin, which is a 3.5-hour flight down to Adelaide. Oh, don't do that. That's a bad thing. So we're consistently told in the UK that patients won't travel to access care. And I'm not sure that's entirely true, or if it is true, it's because that's what we tell them they ought to think. And if you provide patients with the right information, they make different decisions. So we set out to look at this and ask patients who are coming for aneurysm screening directly, if you were to go to a hospital with a 2% lower death rate, or a 2% lower stroke rate, amputation rate, how long would you be prepared to travel beyond your nearest hospital to access that care? And the answer was that 92% would be prepared to travel for an hour or more beyond their nearest hospital to access care with better clinical outcomes, high volume surgery, and better access to minimally invasive surgery. So I think this is all about the information we give to patients in order for them to make informed decisions about their health care. And trying to make something equal that isn't equal is a fallacy. We can't deliver this surgery across all hospitals. Bundling all that together, the clinical outcomes and the travel times, this is a somewhat infamous slide, unfortunately. We came up with a series of networks around the country. There were 242 vascular units when I started this work. And I think we need 48 vascular networks throughout the country. And this takes account of all the travel times we've talked about. In London, ahead of 2010, we had 27 vascular units. We did a large review that dropped that down to 8, and that was only ever meant to be an intermediate step, moving towards a sector-based solution, with one hospital in each sector of London. And we're still at 8, 5 in North London, 3 in South London, although we're doing a lot of work around that. Clearly there's an argument towards strategic service reconfiguration, which will support surgeon specialisation, it'll reduce the unacceptable turndown rates, it'll support the delivery of minimally invasive surgery, the publication of data, it'll also support research. But we've got another problem. last health secretaries, Andrew Lansley, specifically asked that we go and present the data to him. And he left me with a very, very clear message.
What in the name of bloody hell are you not busy? In the name of sanity.
So he said no. And the networking just stopped. We were doing a lot of work on it, and it stopped in the most awful situation that some centres had one procedure on one site, one on another, others hadn't even begun, and others were further along the pathway, and it's just left this chaos across the country. And Lansley just stopped it. I mean, it's quite bizarre behaviour, but there we go. And it's even more bizarre when he's presented with this information. So you've seen this graph before for vascular. But if you take 25 emergency conditions, heart attacks, heart failure, vascular surgery, fractured neck of femur, emergency general surgery, and all sorts of things, including sepsis, and you do that same study where you pull out one procedure or diagnosis, and you compare that to all the others, we have these really strong results. So sepsis, if you have good emergency outcomes for all these procedures other than sepsis, you have a mortality of around 23% from sepsis. If you're less good for the other 24 procedures, you have a 35% mortality from sepsis. It's a real problem. There are some hospitals that are achieving better results than others, and yet some of the health secretaries are just unprepared to deal with that fact and to take these data on board. So we dive deeper into that relationship, and it'll surprise no one, I think, that medicine is all about people, and the answer is all about people. This is all about staffing. Hospitals with more doctors and more nurses do better. Hospitals with more critical care beds, more access to diagnostics, and a greater number of operating theatres. So you invest in infrastructure and you invest in people. And with people like this, how can you possibly That was all the brainchild of John Hutt, one of our orthopaedic surgeons, and we had so much fun at house officers. We didn't really ever leave the hospital, but we had a wonderful time, and that was kind of the sort of thing we got up to. I can't remember really the point of that. Let's stop it. So if you go deeper into this, and you look at the number of doctors per bed, the number of consultants per bed, and the number of nurses per bed, you have hospitals not performing so well in the blue, hospitals performing as expected in the orange, and hospitals performing better than expected in the silver, and whichever way you carve it up, if you have more doctors and more nurses, the outcomes are better. Which brings us to Jeremy. So he is telling us all we all need to work more days of the week, more consistently, but I think given that data, he has been responsible for more doctors and nurses leaving for other pastures than any other person in the history of the NHS. So I think the way in which he addresses this problem is a serious issue, and I think we are staring down the barrel of a staffing crisis within the NHS, the likes of which we've never seen. And I think this needs some very, very serious work very quickly. So drawing to a close now. It doesn't really matter whether you're a classicist or a golfer or a young child who likes to watch The Simpsons, but adopting best practices and making them habit is clearly the best way to achieve the best outcomes from the surgery that we do and the care that we give to patients. This has been taken forward recently by the Getting It Right First Time programme, the GIRFT programme, who released a report on vascular surgery in March of this year, and that was in the BMJ a couple of weeks ago, and the Health Services Journal only yesterday. And this programme's cost 60 million, and they've suggested that a networking model would save lives by reducing the likelihood of patients having strokes, TIAs, aortic aneurysm ruptures, and arterial blockages. And although it is somewhat galling that we've had to pay this enormous amount of money for this review to say what we've been saying for years, I think this has got us back on track, and it'll restart the process that Lansley so damagingly stopped. There will be some procedures that are very esoteric and high risk. It'll be done in specialist units, and wherever Rachel is, as long as George is one of them, we're all happy. So how have we done? These are the major publications for aortic aneurysm surgery over the last 10 years. 2006, the NCPOD report gave us a 10% mortality. We're now down to about 1%. So in many ways this has been a good story. We need to make sure we're treating all the patients, we need to, and we're not just getting good results because we're not treating people. But Ian's led nationally on the publication of results. And this is a whole range of things, but we are getting there. Undoubtedly, I wouldn't be standing here today if it wasn't for a lot of people. And Matt and Ian took me from being an SHO through a lecturer, through a junior consultant, and without Matt and Ian, I definitely wouldn't be standing here today. Alison McGregor and Bob Schroeter from Imperial. When I thought I'd be a spinal surgeon at one point, and anyway, they taught me how to question things and never to stop questioning. As with Janet and Roger, who've supported me for a long time. The clinical lectures, Alan, Ben and Kate, all this work is yours and that of the research fellows and our statisticians, so thank you very much for your hard work, and that of the research nurses. This is a big team, and the theatre staff, ward staff are all integral to how we act and behave in our results. Clearly I've had some funding, and I thank these major funders and charitable trusts for providing funding for this work. And finally, to my family, Anna, Ted and Emily, I thank you so much for supporting me, and whether it's a coffee in the sun, sharing an ice cream, the first time you mastered the monkey bars, or realising that my daughter's got more cool in her little finger than I've ever had. I thank you all very much, and it's a pleasure to have you here today. Thank you.
It's my very easy task to propose a vote of thanks on behalf of the audience for an outstanding lecture, Pete. Many things I could thank you for personally, but that's not the night to do that. I've been involved in the Vascular Society for about 7 years now, and we write documents on the provision of vascular services, how vascular services should be configured, and I can't tell you how many times I've heard the name Holt in the last 7 years. There's often a disconnect between people's research, however high quality, and genuine changes in clinical practice. And I can genuinely say that Pete's not in that situation. His work over the last 10-15 years has genuinely changed the horizon for vascular surgery. So actually I think the country and vascular patients of the future would also join us in thanking Pete for the work he's done. So on that note, we'd all like to thank you, Pete, for a wonderful lecture in the usual manner. Thank you.